Hello, everyone. Welcome to the DAP Note lecture. So DAP notes are a format for writing progress notes. So we will be exploring MSCs, which are mental status exams, and DAP notes. So what I noticed is in a psychiatric setting or a mental health setting where that has a medical component. So for instance, at my job, we have nurses and psychiatrists and doctors on our multidisciplinary team. And typically in those types of settings, you'll be using mental status exams. But if you are a community resource or in SUDS treatment or chemical dependency treatment, you will be likely using DAP notes. So DAP stands for Data, Assessment, and Plan, and that is literally the format of the note. And we'll go ahead and take a look at that. So a DAP note is a method of documentation used by healthcare workers, social workers, and similar professionals. While SOAP notes, so SOAP stands for Subjective Objective Assessment and Plan. It's very similar to a DAP note, except we separate what the patient said and what our opinion or what we offered. We do that separately. So don't worry about that. If you're interested in SOAP notes, there is an optional resource attached to the end of this module. But like I said, here we're going to be focusing strictly on DAP notes. So the DAP note paradigm is more appropriate for behavioral health, I believe, just because it more accurately describes the information that we're looking for. So DAP notes provide behavioral health professionals with a guide for organizing pertinent information from counseling and psychotherapy sessions. Keep in mind too, though, this is a progress note. So if we were actually psychologists or psychotherapists, or when we become therapists, if that's our trajectory, we will be using a different type of note. So we're not going to go into that in this class, but there is different formatting when we are, let's say, providing EMDR, for instance. We wouldn't write a progress note in this fashion necessarily. So don't let that be too confusing. Just know that a DAP note is always going to be assessing progress throughout treatment. So the data component of a DAP note includes everything you heard and observed in the session, okay? It's a review of all the information gathered, and most of this information is client self-report, but clinician observations also provide valuable information. Some of this can also go in the assessment piece, and you'll notice in the examples that sometimes you could either put our observations or the clinician observation in the assessment or the data part. So at times the clinician may inject some subjectivity into the process. For example, they may note that a client appears agitated. An overall question that summarizes the section is, what did I see? So for example, the data piece might start with, patient appears agitated due to throwing her cell phone in her purse, and rolling her eyes or breathing really heavy, something like that. And then in the assessment piece, the difference would be maybe our opinion on what was causing those behaviors. So the assessment portion of the DAP note reflects clinical interpretation. So here are some important questions to answer in the assessment section. Is the client motivated, or are they making an effort to address the issues? How does the data reflect attention to their treatment goals? Are they making progress? And does this data indicate a particular diagnosis or issue to be addressed? In other words, what does the data mean? What is our professional inference on what we have been presented with? Okay. And there will be plenty of examples through this module. The final portion of the DAP note is to plan for future treatment. So what are we going to do next? Where are we going from here? It may involve what you want the client to do, as well as what you, the therapist, want to accomplish. For instance, you may write that the client is to complete a homework assignment, that you need to contact their psychiatrist about medication. Keep in mind, this segment is not the entire treatment plan. It is simply the goal from one session to the next. However, it may include changes or new directions to the overall treatment plan and answers the question, what will I do next? Also, if you have a scheduled next session, this would be the place to add that information. So when writing DAP notes, I would say before you even meet with the patient, identify key notes that you would like to explore. So review the treatment plan. What are the objectives? What do we need to make sure that the patient is progressing towards? So some examples: substance use, a previous conflict with family, job search, also things that aren't on the treatment plan, like our conflict with family wouldn't necessarily be on there, but if we know that they've been having a big blowout with family members, that might be one of the things that we want to address. And so sometimes I actually like to jot down a few notes on a post-it just so I can remember to hit all the points in the session. Also, we want to make sure before we meet with a patient, we review all the documents and all the background information that we can. It actually will help to write our notes later. So the better that we know the patient, the easier it will be to get an accurate assessment of them. We also want to keep DAP notes pretty simple. We don't want a whole bunch of extra fluff, things that do not matter clinically. And again, that comes with practice. The way that I write a note and the way that y'all write a note may be very different, and depending on the clinician themselves, things that may be important to me may not seem important to you, or vice versa. And so we want to keep it simple, straight to the point, but still adequately addressing everything that we need to. And we also, we're going to explore and identify what style works for us. Sometimes when it comes to, so we talked about this in the assessment. I do not like to type on the computer when I'm meeting with a patient. I tend to see people who have a lot of psychotic symptoms and paranoia. And so unless they can see my computer screen, I don't like to type, and that is not the case in my office. And so typically I'll write it on a word pad, just notes. And again, somebody asked me this in the Zoom meeting of like, do you really write down everything? I've been doing this for a long time, and so I kind of work backwards when I'm assessing. So for instance, if I know the diagnosis and symptoms that come along with that diagnosis, and I know that they are experiencing a multitude of those symptoms, I might write patient is experiencing anxiety symptoms minus, let's say, minus racing thoughts. So then I'll be able to keep that in my note. I know that that's kind of abstract. You'll find the more that you practice and the more that you have practice with writing these notes and having these sessions, you'll find what works best for you. And I would highly recommend that before you type during a session, you ask if it's okay, even if it is your preference. So this is an example of a DAP note. So client arrived late and appeared flustered. So again, there's that objectivity that appeared, excuse me, reported feeling stressed and having difficulty implementing mindfulness-based exercises previously reviewed in sessions. I assisted her in practicing the techniques and problem-solving ways to implement at home. So when I first got into the field, using me or I was not appropriate. We would have to write out this writer. I'm not going to mandate that in these assignments, but know that you're like at Peace Health where I work, we would never write I assisted her. It would always be this writer or this provider or this clinician. So just note that at your agency, what they're looking for. The assessment, client appears to be having difficulty managing her needs with family demands, but she remains committed to therapy. The plan, client will practice exercises reviewed in session. Next session is 6/2/16. So this is just an example of a small, quicker session. So yours might be much bigger than this, and that's okay. But what I wanted to depict is this right here. All of this says the exact same thing. as this. We just have a lot of extra fluff. So we don't need to say necessarily how long late for the session. We don't necessarily need, in an MSC, we might say that they were in their workout clothes, but in a DAP note, is it really telling? Is it giving us any more information that she's in her workout clothes? No. We don't need to write that we offered her water, nothing like that. Also, she talked about difficulty concentrating, about how her son kept interrupting her so he could get help with homework. Unless we have some type of parenting, social work type offering in the program that's going to help her with that, this isn't very telling either. So I think in this note, difficulty, she's just feeling stressed. So that kind of encompasses that whole issue with the son. We don't necessarily have to describe the whole thing. Client spent much of the session making excuses for why she probably won't be able to make the exercises at home. So something like this is exactly what we're talking about when we talked about client issues in clinical documentation in the last lecture. We don't want to say this, okay? Making excuses, it's kind of offensive. It might anger people. And so a better way to say something like that is client appeared to be help rejecting, which also doesn't, seem much better. However, clinically, we do need to say that because the next therapist might be beneficial for them to know that they might need to come up with creative ways to motivate the patient. So we do want to add that in there, but not necessarily offensively. Okay, so we'll find other clinical jargon to use that more accurately describes it in a professional way. So review this slide as well as the example and kind of see how a lot of this information could be summed up and tied up with a pretty bow in a more professional way. Again, we do want to accurately and adequately describe the problem and the progress that the patient's made, but we do not need all of this extra stuff. So when I worked in chemical dependency specific treatments, something that was required by us is that we addressed all 6 ASAM dimensions in the data part of the note. So again, this is not something you're going to have to do in this class, but I did want to make sure that people knew what this meant. So this means we're going to be covering withdrawal potential, whether they're intoxicated, what kind of drugs they're using, whether they have any medical conditions or need to see a doctor, whether they have any mental health diagnoses, behavioral, emotional, or cognitive conditions that need to be addressed. And we're also going to address, are they being addressed? Are they going to therapy? Are they seeing a speech therapist? Or not a speech therapist, I'm sorry, a behavioralist. We want to make sure all the information is in there. Then we assess their stage of change. So again, we're not going to go into that in this class, but the stages of change are pre-contemplation, contemplation, action, maintenance, and relapse. Wait, I'm sorry. Pre-contemplation, contemplation, preparation, action, and maintenance. And I think some folks add the relapse to the stage of change model. And so how we would address readiness for change is patient appears to be in the contemplation stage of treatment, evidenced by verbally stating that they would like to cut down their marijuana use, or because they're coming to treatment and attending support groups. So again, we want to provide that evidence. Also, we want to address relapse or continued use potential. So a patient appears to be at high risk for relapse, evidenced by prior failed treatment attempts, or patient appears to be at mild risk for relapse, evidenced by engaging with old partner who uses substances. And then recovery living environment, who's supporting them, are they employed, what does their daily activity look like, are they attending support groups? Those are the types of things. So this is just an example of a note. that would follow this format. So patient reports continued use of marijuana, smoking a couple of joints daily. They report it's the only thing that makes me feel normal. Patient also identifies negative consequences of use and that they would like to stop completely. They report continued abstinence from alcohol and cocaine and report symptoms congruent with mild post-acute withdrawal, including difficulty sleeping, low mood, and increased anxiety. Patient reports they continue to follow up with PCP regarding symptoms and that they do not report any other medical concerns at this time. Patient reports they have been attending outpatient mental health therapy to address symptoms of anxiety and depression, which he was recently diagnosed with earlier this year. Patient appears to be in the action stage of change regarding alcohol and cocaine, evidenced by continued abstinence, involvement in IOP treatment, and attendance to outside support groups. Patient appears to be in the contemplation stage of change regarding marijuana use, evidenced by desire to cease use, with continued ambivalence due to mental health symptom relief. Patient continues to be employed full-time, that they were recently promoted. Patient recently moved in with their fiance and got a new puppy. Patient reports that they meet with social supports and attend support groups twice weekly. So I did forget to add in that relapse piece there. So if I were to go back and add that, it would say, again, patient appears at moderate to severe risk of relapse, evidenced by failed prior treatment attempts in the past. And that is it for that. Again, please reach out if you have any questions at all. I will do my best to get back to you within 24 hours. And if you need, I am also available for Zoom or phone meetings.